Welcome to Lecture 7, Exploring Tax Benefit Systems. The previous lecture showed you what the Landman TTM revealed about a decade of austerity, its scale, its regressiveness, its discriminatory impacts. This lecture uses the same model to answer a different question. What would basic income do? And it goes beyond the static distributional question to ask a second question that no previous study of UK basic income had fully answered. What would basic income do to the nation's health? This lecture has two major movements. The first is static distributional modelling. 3 basic income schemes at widely different levels of generosity, all modelled as revenue-neutral packages using the TTM. The results are dramatic. The second is dynamic health modelling. Using 12 waves of understanding society panel data, we estimate the income-health relationships that allow us to predict how the income redistribution from basic income would translate into changes in depression, physical health problems, quality-adjusted life years, and NHS costs. The health findings are published in PLOS Mental Health, Reed Johnson et al., 2024, peer-reviewed, internationally visible, and the first estimate of health impacts of basic income across the full UK adult population, covering both mental and physical health. The distributional findings are published in the Journal of Poverty and Social Justice, Reed et al., 2023. You will be working with the same methods and the same data sets that produce these papers. If you have access to an account, please have practical demonstrations 7, 8, 9 and 10 open alongside these slides. We cover 10 topics, structured around 2 analytical movements: static distributional modelling, topics 2 to 4, and dynamic health modelling, topics 5 to 10. The first movement addresses affordability and distribution. Can a revenue-neutral basic income package be designed that dramatically reduces poverty and inequality? The answer is yes, and the numbers are large. The second movement addresses health. What would the income redistribution from basic income do to population health, and what is that health improvement worth in economic terms? By the end of this lecture, you will understand how to interpret the full chain from policy design, through distributional modelling, through health impact estimation to economic valuation. This chain, from a policy lever to a QALY value, is what makes the basic income case comprehensively rather than just distributionally, and it is what makes the research politically significant as well as academically important. It is useful to begin by understanding the rationale for basic income. Guy Standing frames basic income as a response to 8 interlocking crises that define the current period: inequality, insecurity, debt, stress, precarity, technological disruption, ecological emergency, and the rise of right-wing populism. The argument is not that basic income solves each of these individually, but that it addresses the underlying material conditions, income insecurity and inequality, that drive all of them. This is what makes it a multi-purpose policy instrument in the terms of the literature the textbook reviews. The Manitoba Income, MINCOME experiment in Manitoba, Canada, run between 1974 and 1979, remains the most influential early evidence on basic income's effects. Forget's 2013 analysis used administrative health data to show that MINCOME participants had an 8.5% lower hospitalisation rate than the control group from other areas of Manitoba, with the largest effects in accidents, injuries and mental health. This is the kind of real-world experimental evidence that policy advocates have been citing ever since. The labour supply question is the most politically salient concern about basic income, and the textbook addresses it directly. The estimated negative labour supply effects from pilot studies are small if they exist at all, and some studies show positive effects. There are good theoretical reasons for this. By eliminating poverty traps, the 100% effective marginal tax rates that occur when means-tested benefits are withdrawn, pound for pound as earnings rise, basic income can actually improve the financial return to taking paid work for some of the lowest income households. The Welsh Government pilot for care leavers is the most relevant recent UK evidence. It is a targeted rather than universal scheme, paying approximately £1,600 per month to young people leaving care in Wales at the age of 18. The evaluation is ongoing and will provide UK-specific evidence on health, well-being and employment outcomes that will be important for the next round of policy advocacy. The embedded YouTube video explains the rationale for basic income more fully. The development of the basic income modelling in this lecture follows a clear intellectual trajectory. Lansley and Reed's 2019 report for Compass established that a starter scheme was both affordable and distributionally progressive. The child poverty reduction from 29% to 18% in a single Parliament timeframe is a striking result, equivalent to lifting approximately 1.5 million children out of poverty. Martinelli's 2020 critique posed a specific challenge. If a starter scheme is modest almost by definition, any scheme generous enough to actually replace means-tested benefits as the primary income floor would be unaffordably expensive. Reed et al. 2023 was designed to address this challenge directly. The three-scheme analysis demonstrates that the range from starter to minimum income standard, MIS, level basic income, can in principle be funded through income tax alone, without requiring wealth taxes, corporation taxes, or environmental levies that might be part of a politically realistic package. MIS is a research-based income benchmark calculated by the University of Loughborough, representing the minimum needed for a socially acceptable standard of living, as determined through deliberation with members of the public. This matters analytically. If fiscal neutrality is achievable through income tax reform, then other tax measures would only improve the position. The high tax rates required for Scheme 3 are genuinely politically challenging, but their inclusion in the paper demonstrates the theoretical feasibility in a way that cannot be dismissed as financial illiteracy. The funding mechanism for the Scheme 1 is worth understanding in detail. The basic income payment replaces child benefit and the state pension. For those receiving it, those benefits are abolished. The additional cost is met by abolishing the income tax personal allowance, so everyone pays tax from their first pound of income, and by increasing all income tax rates by 3 pence in the pound. The abolition of the personal allowance is progressive when combined with the basic income payment, because higher earners lose a larger tax-free amount but receive the same basic income as everyone else. Let me work through the specific numbers, because they are important to know precisely, both for analytical purposes and for public communication. Scheme 1, the starter scheme, is the most politically salient because it is the one designed to be fiscally neutral. At £63 per week for working-age adults, it is not far above the current Universal Credit's standard rate of approximately £90 per week. The income tax rates required, 23% basic, 43% higher, 48% additional, represent increases of 3 percentage points across all bands from current levels, combined with the near abolition of the personal allowance. This combination is progressive. High earners pay more, but receive the same basic income payment as everyone else. Scheme 3, at minimum income, standard level, pays £230 per week to working-age adults and £95 per week to children. The MIS is the income standard defined by researchers at the University of Loughborough for the Joseph Rowntree Foundation as the minimum needed for a socially acceptable living standard, as determined by members of the public through deliberative research. The tax rates required for fiscal neutrality through income tax alone are very high. 65% basic, 85% higher, 95% additional. These are not intended as a realistic immediate policy prescription. They are included to demonstrate that the theoretical ceiling of income tax-funded basic income can reach MIS level. The retention of universal credit is important to understand. Under all three schemes, the basic income payment is counted as unearned income in the universal credit calculation. This means that for households receiving UC, the basic income is partly offset by a reduction in their UC entitlement. For schemes 1 and 2, a small disregard is applied so that even UC recipients are better off under basic income than without it. For scheme 3, the payment is sufficiently high that no disregard is necessary. The BI payment alone exceeds most UC entitlements. The distributional outcomes from the Reed et al. 2023 analysis are among the most striking in the recent UK microsimulation literature. Let me work through the headline numbers precisely. Under Scheme 1, the starter scheme, which is fiscally neutral, average incomes in the lowest income decile rise by approximately 140%. AHC child poverty falls from 29.2% to 13.5%. The Gini coefficient on household incomes after housing costs falls from 0.394 to 0.331. A child poverty rate of 13.5% AHC would be the lowest recorded since 1977, lower than at any point during the Blair or Brown governments. This from a scheme that costs no net additional public spending. Under Scheme 3, the numbers are more dramatic. Average incomes in the lowest decile rise by 534%, more than 6 times, and AHC child poverty falls to 3.8%. The top income decile's average net income falls by around 30% due to the very high income tax rate. These are not prescriptive numbers. They demonstrate the range of what is achievable at different levels of generosity and tax ambition. The non-take-up explanation is important for interpreting these results honestly. The 140% income increase in the lowest decile is not entirely a reflection of the basic income payment itself. A substantial part of it reflects the elimination of the non-take-up problem. Some households in the lowest decile have very low recorded incomes, precisely because they are entitled to universal credit but are not claiming it. When basic income replaces UC for their income category, they automatically receive the payment. There is nothing to claim, no application to complete, no stigma to navigate. The universal design of basic income is therefore not just philosophically attractive, it is distributionally powerful through the mechanism of eliminating non-take-up. The move from static distributional modelling to dynamic health modelling is the methodological core of this lecture. Let me explain why this matters and what the specific research contribution is. The evidence that income affects health is extensive and well-reviewed. The textbook cites studies on self-rated health, mortality, biomarkers, child development, and adult mental health across multiple countries and methodologies. The absolute income hypothesis, that more income produces better health with diminishing returns, is well supported. The income inequality hypothesis, that inequality in itself harms health across the distribution, not just at the bottom, is more contested. But there is growing evidence, including Wilkinson and Pickett's spirit level, that it captures something real about how inequality affects social trust, stress, and health behaviour. The Common Sense's basic income health logic model traces the causal pathway the research is testing. Basic income directly increases income and reduces poverty. It also increases income predictability and security. This is a distinct pathway from the absolute income level, reflecting the evidence that volatility and uncertainty in income are independently harmful to health. These improvements in material conditions reduce chronic stress and improve access to health-promoting goods and environments. These in turn reduce the prevalence of depression and physical health problems, improving population health and reducing NHS utilisation. The specific research gap this study fills is important for understanding its contribution. Prior UK microsimulation of basic income's health effects had focused exclusively on mental health and often on specific age groups. Thompson et al. 2024, published after the Reed et al. Findings were drafted, focuses on adults aged 25 to 64 and uses the General Health Questionnaire, GHQ, 12 mental health measure. This study is the first to estimate health impacts of basic income across all UK adults, 18 plus, and to cover both mental and physical health in a framework that allows conversion to QALYs for health economic comparison. The methodological choice of the within-between model is not arbitrary. It is driven by specific features of the research question and by the properties of the UK Household Longitudinal Study, UK's HLS, data. The UK HLS, widely known as Understanding Society, is a large-scale longitudinal panel survey tracking around 40,000 UK households annually across health, income, employment, and social attitudes. Let me explain the logic carefully. The standard problem with estimating income effects on health from cross-sectional data is confounding. Healthier people tend to earn more. People with higher incomes live in healthier environments. Childhood circumstances affect both adult income and adult health. A simple regression of health on income in cross-sectional data cannot separate these confounded effects from the causal effect of income on health. Longitudinal data helps by exploiting variation over time within the same individual. When the same person's income increases from one wave to the next, factors like their childhood background, personality, and genetic health endowment cannot have changed. If their health also improves, that change is more plausibly attributable to the income change than to stable background characteristics. This is the within component of the within-between model. The between component asks a different question. Do people who have higher average incomes across all 12 waves of the study have better average health than people with lower average incomes? This captures the longer-run, more permanent income-health relationship. It also captures something additional: the relative position in the income distribution, which Wilkinson and Pickett's spirit-level research suggests is independently health-relevant through mechanisms of social status comparison and trust. For predicting the health effects of basic income, the between coefficient is the right one to use. Basic income is not a temporary income shock. It is a permanent policy change that would alter households' income levels indefinitely. The between coefficient, which captures permanent income level differences, is therefore the appropriate basis for the prediction. Using the within coefficient would underestimate the health effects by treating basic income as if it were a transient income change. The health economic framework in this section provides the methodology for translating income changes, which the TTM calculates precisely, into health outcomes and then into economic units that health economists and policymakers can interpret and compare. The SF12 is a 12-item survey instrument that generates 2 summary scores from responses to questions about physical functioning, role limitations, social functioning, bodily pain, mental health, and vitality. Both mental component summary, MCS 12, and physical component summary, PCS 12, are collected in an Understanding Society, which is why UKHLS data can support this analysis, while the FRS cannot. The FRS does not collect SF12 data. The clinical thresholds define what the analysis means by a case of depressive disorder or a clinically significant physical health problem. An MCS12 score of 45.6 or below is the established threshold for depressive disorder in the clinical literature. A PCS12 score of 50 or below indicates clinically significant physical health problems. These thresholds allow us to count cases, the number of people above versus below the clinical threshold, rather than just changes in average scores, which is more meaningful for public health communication. The conversion from SF12 to SF6D to QALYs involves proprietary software from Quality Metric that implements the validated algorithm developed by Brazier and Roberts. The SF6D utility index ranges from 0, death, to 1, perfect health. Multiplied by time in years, this gives QALYs. The National Institute for Health and Care Excellence NICE threshold of £30,000 per QALY is used throughout. This is the standard for health technology assessment in England. NICE is the independent body that evaluates the clinical and cost-effectiveness of medicines and public health interventions. Its £30,000 per QALY threshold is the benchmark used throughout this course. The Treasury Green Book proposes a higher value of £70,000, but NICE's threshold is used here to produce conservative, defensible estimates. Multiplying by 2.33 gives the Green Book value if needed. These are the headline numbers from the PLOS mental health paper, the first peer-reviewed estimate of health impacts of basic income across the full UK adult population, covering both mental and physical health. Starting with Scheme 1, the starter scheme, fiscally neutral, requiring no net increase in public spending. Between 86,000 and 150,000 cases of depressive disorder are prevented or postponed each year. Approximately 118,000 cases of clinically significant physical health problems. Around 129,000 quality-adjusted life years gained annually. The value of those QALYs at the NICE threshold is £3.87 billion. NHS and personal social services cost savings are £126 million per year. Total savings including patients' costs are £563 million. These are significant numbers for a scheme that costs nothing net in static fiscal terms. A fiscally neutral reorganisation of the tax and benefit system produces £126 million in annual NHS savings and prevents 124,000 cases of clinical depression each year. The health economic case for basic income does not require accepting additional public spending. It holds even for the revenue-neutral starter scheme. We need to be careful about the limitations of these estimates. They are described as conservative for two reasons. First, they are based on income level effects only. The between coefficient captures permanent differences in income levels but does not fully capture the additional health gains from improved income security and predictability, from reduced destitution risk, or from changes in subjective social status inequality. Second, the cost of living crisis of 2022 to 23, which compressed household incomes and accelerated health deterioration through the pathways in the logic model, suggests that the current health need is larger than the 2021 to 22 FRS baseline implies. Both factors push in the direction of the estimates being underestimates. The nurse equivalent is worth using in communication with policymakers. Scheme 1's NHS savings could pay for 7,481 additional Band 5 nurses per year. Scheme 3's savings could pay for 61,184. These concrete, verifiable numbers communicate the scale of the health system return in a way that QALY values, however accurate, do not resonate with non-specialist audiences. The fundamental reframing that these findings enable is treating basic income as a health intervention rather than purely a welfare measure. If basic income prevents 124,000 cases of clinical depression per year at no net fiscal cost, it is not just a redistribution policy, it is a public health investment with a demonstrably positive return. This reframing is analytically important because it brings a different set of policy advocates into the conversation: clinicians, public health professionals, NHS commissioners, and the Treasury officials responsible for healthcare budgets. The gender dimension is worth noting explicitly. The redistributive impacts of basic income schemes benefit women more than men on average, reflecting women's lower average incomes and disproportionate concentration in part-time, low-paid, and unpaid care work. This connects the basic income case to the gender equality argument in ways that purely distributional analysis by decile cannot fully capture. The conservative estimate problem is the most important caveat. The model captures the health effects of permanent income level changes, using the between coefficient from the UKHLS income health regression. It does not capture the additional health benefits of income security, the psychological well-being effects of knowing that a regular payment will arrive regardless of employment status. It does not capture the effects of eliminating the destitution risk that many households face from benefit conditionality and sanctions. And it does not capture the full subjective inequality pathway that Wilkinson and Pickett's research identifies. All of these additional pathways would produce further health improvements beyond those estimated. The reported numbers are a floor, not a ceiling. The research agenda is straightforward. Large-scale experimental studies are needed to provide the certainty that observational modelling cannot achieve, and modelling through all the pathways in the logic model, not just income level, for all major disease types would dramatically increase the specificity and credibility of the health savings estimates. This is genuinely important future work, and this lecture represents the first systematic step toward it. The title of this conclusion, Upstream Economics as Health Policy, captures the lecture's most important intellectual move. We began with basic income as a fiscal reform, a revenue-neutral restructuring of the direct tax and benefit system. We ended with basic income as a public health intervention, preventing 1 million depression cases per year under Scheme 3, generating 655,000 QALYs, saving the NHS and personal social services £1 billion annually. The same policy, evaluated through two different lenses, is both things simultaneously. Together they constitute a more complete case than either alone. The first thread is fiscal neutrality and the affordability objection. The critique that basic income is unaffordable has been the dominant obstacle in policy debate. Reed et al.'s modelling addresses it directly. The starter scheme is revenue neutral, funded entirely by income tax reform, requiring a basic rate of 23%, barely above the current 20%. It costs nothing in net public spending terms, and under it AHC child poverty falls from 29.2% to 13.5%, the lowest rate since 1977. The Martinelli trilemma, that you cannot simultaneously have a basic income that is affordable, adequate and administratively simple, is real at Scheme 3 level. At Scheme 1 level, it is not the binding constraint. The second thread is the within-between model. The choice between within and between coefficients is the central methodological decision of the health microsimulation. The within coefficient captures temporary income shocks. The between coefficient captures permanent income level differences. The right coefficient for estimating the health impact of a permanent policy change, because basic income is not a temporary transfer, but a structural change to every household's income floor. That decision is what makes this a valid health microsimulation rather than a cross-sectional correlation. The third thread is the scale of the health returns. The Scheme 1 numbers deserve emphasis. 124,000 depression cases prevented per year, 118,000 significant physical health problems prevented, 129,000 QALYs generated, £3.87 billion of QALY value at the NICE threshold of £30,000 per QALY, £126 million in NHS and personal social services savings, and the equivalent of 7,481 additional Band 5 nurses funded annually, all from a scheme costing nothing in net public spending. At Scheme 3 level, the health returns are approximately 5 times larger. Using the NICE threshold ensures the comparison is meaningful to health economists and to NICE itself. The fourth thread is the non-take-up mechanism. The 140% income increase in the lowest decile under Scheme 1 is not primarily driven by the basic income payment. It is driven by the elimination of non-take-up. Many households in the lowest decile are there not because they have no entitlement, but because they are not claiming it, facing barriers of stigma, complexity, digital exclusion, or fear of conditionality. Universal basic income bypasses all of these because it is paid automatically to everyone. For these households, the income gain is not a policy gift. It is the correction of a systematic failure to reach the people the current system is designed to help. The fifth thread is the conservative estimate problem. Every pathway excluded from the model, income security effects, destitution protection, reduced income volatility, subjective inequality pathways, is excluded not because it does not exist, but because we lack well-identified causal estimates of its magnitude. The between coefficient does not capture the additional health gain from the predictability and security basic income provides over and above its income level effect. The cost of living crisis of 2022 to 23 accelerated health deterioration through exactly these pathways. The published figures are a floor, not a ceiling. Lecture 8 asks what the distributional and health evidence alone cannot answer. What does the public actually think, and can a party implement this policy without electoral damage? The conjoint analysis tests public preferences across basic income's attributes, using trade-off designs that overcome the well-documented problems with single-question polling. The analytical journey from distributional microsimulation through health microsimulation to public opinion measurement is not a sequence of separate methods. It is a single integrated argument for a policy that is affordable, effective, and more popular than the political class currently assumes. If you have an account, please move on to practical demonstrations 7, 8, 9, and 10.